Thank you so much for taking the time on this crazy Tuesday and spending some time with us to participate in this rural engagement. So I'm just going to hand it off to my boss, Callie, to talk about what we're here for. There you go. Sorry.
Awesome. Thank you very much. Thanks for joining us. My name is Callie Barr. I'm running for Congress here in Michigan's 1st Congressional District. And thanks for taking time. I know today's a busy day. We have right now our government facing a shutdown. And, that's because of folks like our current representative, Jack Bergman, who is unwilling to extend the ACA subsidies, which helps folks in our district in upper and northern Michigan pay for health insurance. He also refuses to reverse the Medicaid cuts that he voted for, that he said he wouldn't, but he did, that funds our rural hospitals. Okay, so this is urgent. If these cuts remain, if health insurance is less accessible because of rising costs, we're not gonna have healthcare in rural areas, right? This is a dire situation. We absolutely depend on Medicaid. Hospitals here are already on very tight margins and struggling to survive. We know we lost the hospital in Ontonagon in 2023. In Keweenaw, we lost the labor and delivery in December of 2024. So we already have challenges that we know about. Add these cuts. In 2025 already, we've lost labor and delivery in Tawas, labor and delivery in Ironwood. Of course, labor and delivery are programs that don't make money. And so this is something we can expect to see more of. In Grayling, we're now projected to see that labor and delivery close in 2026, along with their critical care as that consolidates in Otsego. So we have people now that are going to be driving farther distances when minutes matter. I think about in Ironwood in the UP, we're going to have folks that are now driving likely into Wisconsin. And I don't think any parent wants to ever be in a situation where they're having a baby on the side of the road. But that's what we're looking at, right? So the thing is that hospitals are having a tough time, and without the ACA subsidies, our health insurance costs are going to go up. People aren't going to be able to afford that when you consider all other rising costs. And so they'll lose health insurance, but it won't stop them from going to the hospital, and the hospital is going to have a hard time absorbing that. The higher premiums that we're going to see look to be projected could be 70 to 89% for some families. For some employers, it could be up to 60% increase in cost. So we just can't afford this. Healthcare is the cornerstone of a good life, of a healthy community. It's also a major part of our economy. And so I brought on two folks to help us talk about this. I'd like to introduce Jamie Mills, who's on the call with us. She's a licensed consultant for employee benefit plans. She specializes in healthcare coverage and employer-based solutions. And she's in the midst of this right now. And, she knows exactly what our employers are facing and the trickle-down impacts of that. So, Jamie, I'll pass the baton here.
Great. As Callie mentioned, I'm a certified employee benefits specialist, and my field has always been really dealing with employer-sponsored healthcare plans. So those can be large employers who are self-funded or smaller employers who are fully insured. For fully insured employers, this is becoming the worst renewal season I have seen since I started in business, which was in 1986. So a long time. We are seeing rate increases that average not only 20% to 60%, we're seeing the plan designs that employees are being shifted to with very high deductibles. So you can have a healthcare plan, but if your deductible is $4,000 or $5,000 and you're earning $15 or $16 an hour, in their perception, and rightfully so, they don't have healthcare. And what we're seeing is employees will delay going to the doctor, will delay going to see a specialist, and will end up by delaying care because of the cost and having to front that money until the employer plan or the insurance company pays. They'll end up going to the emergency room, which is the worst place for delivery of care. It's not only the most expensive place because of the technology that emergency rooms need, but it also isn't the best care. We need to focus on preventive care and taking care of individuals on the front end, not reacting to what's happening on the back end. So what employers are faced with, and unfortunately for many employees, they blame their employer for contributions that are escalating, when in fact, it's the whole system that is crashing. If Medicaid cuts go through, as they're mentioning, hospitals are already raising their prices. Physicians are raising their prices because they know what's coming down the pike. They're going to be having quite a bit of uncompensated care. With uncompensated care, somebody has to pay for it. So they will shift those costs to employer plans by, if you're a self-funded plan, you're going to pay higher claim costs. If you're an insured plan, you will pay higher premiums. The employers in return, and not because they want to, but because they have to also be profitable, they will then turn around and raise contributions to the employees. And I work with many employers and nobody wants to do that. But they don't have a choice either. They have to remain profitable, second largest cost next. So it's, it's a bad situation for everyone. So now the employees have higher contributions. That affects their morale. An employer can only charge 9.9% for single coverage, but they can charge whatever they need to for family coverage. So what I anticipate seeing is that employees will be covered for health insurance, but not their families, because the cost for them at $400 or $500 or $800 a month is impractical and unrealistic if you're earning $15 an hour. So what we're seeing with Medicaid cuts, there's a lot of focus, as Callie mentioned, on the enhanced subsidies, which if they don't come back, may be the reason that our government shuts down. There's the trend of what's happening to hospitals, rural hospitals and rural doctors that Richard's going to talk about, but nobody's focusing on the employers. This is a huge problem for employers. They are trying to figure out how do they provide it, how do they provide health care that's affordable for their employees, and they're running out of solutions. And this is the first time that I have ever seen employers say to me, I can't continue to offer coverage. And I have never heard that from reputable employers who truly care about their employees. The costs are escalating just too much to make it feasible for them to continue to offer it. That's kind of how the employees look. And Richard, I know you're going to talk about how it looks for the facilities. And so I'll turn that over to you.
Thank you, Jamie. And that's, exactly right. That we have trickle down effects then if folks can't insure their families and they can't have insurance, rising costs that will impact our local economies, that impacts our hospitals. I'm now going to introduce Richard Douglas, PhD. He's a social epidemiologist with more than 5 decades of experience in public health policy, medical history. He's a former professor at Eastern Michigan University, a partner at the Rural Health Group, researches non-emergency medical transportation in rural Michigan. He's the author of several books, and he's going to tell us some more about the impact on our nursing homes, economic impacts in the region. Richard, thanks so much for joining us.
Well, I'm glad to be here, and I'll try not to duplicate what Jamie so astutely said. One of the things about CD1, especially that we need to pay attention to, is the aging of the population. Mm-hmm. Alcona County, just north of Iosco, where I live, is the 4th oldest demographic county in the United States. It makes St. Petersburg, Florida, look like a kindergarten. And the reality of that is that we've lost so many people because of the lack of jobs. We've lost a lot of people, the younger families. So we've got a very high dependent population of elderly people that are in place, aging in place. If you look at the nursing homes and the vulnerability of the nursing homes to what's going on, cuts to nursing homes would be catastrophic. The nursing homes in the Upper Peninsula and the rest of CD1 are about 78% Medicaid dependent, which means they stay afloat 2% financial margin. They can't survive on a 22% margin. So if you take out the foundation of Medicaid from these places, they will close. Well, what do you do with the nursing home patients? Well, you stick them in the nearest hospital, but we don't have as many hospitals as we did. So where do you put them? They may be sent way out of state, like in Wisconsin, where they might have a bed available. And that bed will be paid for by Medicaid at 5 or 6 times the rate in the hospital that would have been costing Medicaid if the nursing home stayed in business. So we're killing ourselves at both ends. We're pushing people to the most expensive venues of care. And then if you look at the larger community impact, all of these facilities, nursing homes and hospitals, have a wide array of community jobs. Janitors, staff, 24 hours a day, hospitality and housekeeping services, all of these are contracted out. And these are fundamental parts of rural community economies. So it's not just the patients that suffer, not just that Medicaid gets ripped off. It's that the whole community loses its benchmark elements of their economy. And even if these are minimum wage jobs, they're the only jobs that are available. People will die. People will die. And people will be abused by having to move long distances away from their only visitors. If you're a nursing home patient, the thing that keeps you alive is your visitors. Well, if you're in Iron Mountain and now you're being moved to Green Bay because that's where a bed's available, go down once a week in the winter to see mom. It's not going to happen. It's not going to happen. I know nursing home administrators in CD1 who have not taken their own paychecks in order to keep their staff afloat. It's that fragile. So if you take a fragile system and kick it in the teeth, you're going to suffer. And we're going to have implications that are very, very dramatic. That's my 3 minutes.
Thank you so much, Richard. And I think that's, if there's anything that we were to get across today, it's how dire this situation is. And I think hearing from Richard saying people will die is not being dramatic. This is absolutely what we expect to see as these ACA subsidies are not extended and as these Medicaid cuts continue to take impact, right? Because we already know that hospitals and healthcare providers and medical personnel, they're already looking and trying to plan for this right now. We need to
another comment. Trump and the Republicans tried to kill the ACA over 40 times in Congress, and they always fail. Coming in the back door to hurt the ACA is what's going on. It's a continued assault on expansion of Medicare availability.
Right. And I think this highlights the importance of extending these subsidies and, of course, reversing these Medicaid cuts. But I'd like to open it up if anyone has any questions.
Yeah, and everything's on the record as well. So if someone can just unmute themselves, a reporter has a question, unmute themselves, introduce themselves in the outlet, and then, direct it to the person you want to ask that question to or entire group. Please ask questions.
This is Eric Dorr. Go ahead.
No, go ahead.
This is Eric Dorr with the St. Ignace News. There was some audio glitching on Richard's last comment there, and I just wanted to confirm, what was he saying before the bit about Trump is coming in the back door to hurt the ACA?
The recent attacks on the ACA, the backdoor attempt to gut the ACA's success. The ACA did not eliminate medical indigence, but it cut it in half. So we, at one point, 40 to 30 years ago, we were looking at 20% of the population with no health insurance at all. Now with the ACA, we've dropped that down to about 10%. What the effort from the Republicans has been, which would have the effect of reducing coverage and moving us back toward 20% of the population as medically indigent. The institutions carry all of that cost, and they have to pass it on or they go out of business. So it makes a fragile system much more damaged, and we're moving backward.
Eric, did you get all that before we move to the next?
Yes.
Thanks. All right. Who else do we got?
I have a question for Callie Barr, if that is appropriate. My name is Kayla Vicarious, and I'm from the Alpena News. The Associated Press just put out a report that the Trump administration has struck a deal with Pfizer to invest $7 billion into manufacturing in manufacturing facilities in the United States, and they're saying that this will potentially lower drug costs and therefore lower Medicaid costs. I was wondering if you wanted to comment on that, or if you think that this is a potential, deal that could lead to lower Medicaid costs.
So of course I'd have to know a little bit more about that, but I'd like to point out that just because a drug is manufactured here does not mean that it's cheaper for us to buy, right? One thing that we need to make sure is that we know how much drugs cost, that we can negotiate any drug here in the United States, which is not currently the case. So without having taken a look at that, what I can say is that without those additional agreements, also I believe we shouldn't have non-disclosure agreements with insurance companies, meaning that they can hide how much things are. We need a lot more transparency. What we have is folks who think that this is like a market system in healthcare, but it's not a market system if we don't have transparency of what things cost, right? And even with our drug cost, there's coupons people use. Some people get them for certain costs, other people get them for much more. But to be able to negotiate for any drug cost is what's going to be really important in driving down those costs. I'm sure that Richard and Jamie could add on to this too. I know Jamie deals a lot with our pharmaceuticals. Jamie, can you add on to this? You're muted. Still muted.
Okay. I look at pharmaceutical costs as very complex. It's like peeling an onion to find out what the actual cost of a drug is. So there are a lot of different avenues. There's a lot of different rebates where some drugs you pay for a drug, but then the employer gets a big rebate back on the cost of that drug, or the hospital gets a rebate back on the cost. So what we've never done is actually looked at what's the cost of the drug for research, for development, for marketing. I'm not saying they shouldn't make a profit. There are tremendous new life-saving medications out there that keep people out of the hospital. And so we need to clean up that entire industry and start from the bottom. What's the cost? How does the manufacturer of that drug get paid for the development and research associated with that drug? How do we bring that drug to market so it's equally and fair, and how is there a profit associated with it? I think one of the things with the drug things, and I haven't really read the new deal that Trump made with Pfizer, but he just put 100% tariff on any drug that's imported, and most drugs are imported. Most drugs come from India or Ireland. So, and that's the way it's always been. I don't think any antibiotics are made in the United States at all. So there's a lot of putting an import tax and then cutting a deal with Pfizer is kind of like talking out of both sides of your mouth, is from what I can determine. But one of the things is that he's cut back on research and development, and scientists are leaving the United States. We need those scientists here. We need that research here. to build a facility where the drugs are going to be made here, that's great. I'm not against that. But I'm also saying if we don't keep our research scientists here who are developing these medications, we're in a bigger problem than we are if, depending on where they're going to be manufactured. The pipeline for drugs is amazing. There are drugs now that if you have certain cancers, you have a chronic disease versus a death sentence. But those drugs cost 25, 50,000 a month. I can tell you the Medicaid recipients are not getting those drugs. So that's another whole issue where we're looking at, a class system. But we need those drugs to keep coming. And to do that, we need scientists and we need researchers. So I'm not really concerned about where they're manufactured right now. I'm concerned that we keep up with the technology and the research that is making people who had a death sentence for an illness who truly now have flipped that to a chronic disease because of that medication. So
Right. Thank you, Jamie. So and that's it, right? We can't look at one thing completely in isolation, especially when we're saying we want to reduce costs. That there's more things to consider here, including, like Jamie mentioned, tariffs on drugs that we bring in that we don't make yet that increase costs, making sure we know the actual cost of a drug, that we can negotiate those, and that we're also not creating a hostile environment for research and development.
Richard put a cool book in the chat as well if you all want to nerd out. I just pulled it up right now and I was all like, that seems cool.
If you say please, I will send you a PDF of the book because Cambridge Scholars wants $100 for it. I would be happy to send anybody on this call the PDF for the whole book. So send me an email, request the book, and I'll send it to you today. One of the things that I discuss in the book is the rise of pharma and what a sham it is, because we pay for the drugs 3 times. We pay for the drugs through government, usually supported research for the basic science. And then pharma will cherry pick the most promising results of that federally funded NIH research, what's left of it now, and take something to market. They will take a 100% tax deduction on the preparation of that drug for the marketplace. That's what they call research. They've already got a good drug because the government already paid for it, and private sector will never assume the risks of basic biomedical research. That's what NIH is for. The drug companies will take it to market, take a tax deduction for that. So we've paid again because a tax deduction is simply shifting the tax burden to us. And then they charge retail prices for the drug. When my wife had cancer, it was a Tarceva targeted therapy. It was $240 per pill every day. For one pill per day, which is hundreds of thousands of dollars. And Medicare paid for that with a $600 copay. If you didn't have the copay of $600, you couldn't even get it. It's an obscene price. And a friend of mine at University of Windsor said the same drug, same dose, was $1,600 a month and no copay.
Thank you for that example.
Thank you, Richard. Any other questions from the press or attendees? Just feel free to unmute yourself.
This is Eric Dorr with the St. Ignace News. Is there anything that can be done without, kind of the federal level assistance to help these communities and these hospitals in the current? Is there any, sort of way to get the word out or get assistance through other means with these issues in Washington?
Good question. The Trump administration is trying to push everything onto the states. And the states have no capacity to replace federal money. And the Republicans in this state will not raise taxes to fill the void. So I think we're talking big money, and I don't see any happy hands going up to saying I can help.
One thing, if I'm not sure if I'm unmuted there. Am I unmuted? Okay. I concur with what Richard said, but a lot of people don't understand that Medicaid is a joint program between the state and the federal government. You know, states have to balance their budget. They can't print money. So for Michigan and for all states, if that cost sharing goes away from the federal government, there is no possible way, even with the most philanthropic people in the world in our state, which we have, there is no possible way that we can make up that deficit between the cost share. I mean, their cost share is about 65% for the state of Michigan. Where can that dollars be recouped would be almost impossible. So we know we're facing a crisis, and it's not a make-believe crisis. It's, you know, right now I know they're saying, oh, it's all because we give illegal aliens, you know, healthcare. That is ridiculous. We are in a healthcare crisis because we are looking at a 65% or a 55% reduction in what we get from the federal government, and it's just not absorbable from the state level. It
Sure.
isn't. It's just, and anyone who says it is, it's impossible. We can't cut enough services in other areas to make up that deficit. Healthcare is one of the leading costs within our state's budget, our federal budget, employers' budget. And so we need to find a way to bring the overall cost in this system down so it works for the average person. Because I concur with Richard, at the rate we're going, people are going to die from delay of care and uncompensated care. You know, people have pride, and I have seen this throughout my career. Somebody who can't afford to go to the doctor, even if we provide them with coupons and passes, they are embarrassed and they don't want the handout. They really don't. And that really hurts because they don't go to the physician even when there are times where there might be some aid for them because of their connotation that taking aid is taking something. They're hardworking, working poor individuals who can't afford healthcare without a handout versus I call it a hand up, not a handout, but they are embarrassed to even take that. So we have to fix the system.
If I can follow up on that, people were even too embarrassed to ask neighbors and friends to take them to medical care.
Right.
In the study we just completed, 26% of people over 60 had difficulty getting medical care. 9.4% were dropped from care. 9.4%. That's thousands of people in CD1 who are dropping their medical care simply because they can't get there for routine appointments. That means they will have an emergency crisis down the road. And you know, what we're working on right now is to try to find alternatives for non-emergency medical transportation. It's a real crisis. It's a real crisis. It isn't tomorrow. It isn't anything except yesterday.
That's right. And I think too, we've reached we're at a point where this is not a right left thing. This is about simply taking care of our community here. We need hospitals. Republicans need hospitals. Democrats need hospitals. Libertarians need hospitals. Every single person is going to need a doctor or a nurse or healthcare in their lifetime. And it's unconscionable to me. It's unforgivable to me to have a representative of a rural area like ours literally be willing to shut down the government, to not extend these subsidies, and to have Medicaid cuts that are going to have these devastating, and already are devastating, impacts to our community here in Upper and Northern Michigan. So we are at a crisis situation. I think, you know, when we think about what can we do right now, Of course, like Richard points out, we have people who can't even make it to their appointments. This is going to be exacerbated as we see consolidation and people having to drive further as services end and as things close. Anything we can do to help with transportation, even if it's volunteer networks, as we try to get people to the hospital. Of course, telehealth, but that's also reliant on us having reliable internet to try to help people with appointments. But there's really no sugarcoating how devastating this is. And I think we all need to be really aware of that and be honest about what it means to be a part of a community and to care about each other. And really, this will impact all of us, right? Healthcare, our economy here in Upper and Northern Michigan.
If there isn't any more questions, I will do follow-ups with the media. I want to just say thank you for everyone for being on this call. I appreciate you taking time out of an insane Tuesday for the world and for your state. So thank you, thank you, thank you. This is an important topic, and we'll follow up with some talking points as well.